So before I begin, I have to disclose that there are no relevant financial or non-financial relationships associated with this work. I would also like to acknowledge my mentor and supervisor here at the University of Texas at Dallas, Dr. Callier, for assisting me in learning how to perform systematic reviews and meta-analyses, and also for her insights and suggestions along the way to completing this project. I would also like to thank Jennifer King and Miriam Kabakcha for performing reliability analyses, both at the citation evaluation and data extraction phases of this project. I'd also like to thank the other members of the Speech, Language, Cognition, and Communication Lab here at UTD for their helpful suggestions along the way. So a little bit of background. Why am I interested in looking at risk factors for SLI? Well, SLI is typically defined as significant deficits in expressive and/or receptive language abilities in the absence of an obvious cause. And some of these obvious causes could be things like hearing loss or deafness, intellectual disability, frank neurological damage such as cerebral palsy or traumatic brain injury, oral structural abnormalities such as cleft palate, social deficits like autism spectrum disorders, or other developmental disabilities or delays. And even though SLI isn't associated with any of these conditions, it is much more prevalent than any of these individually, and quite possibly more prevalent than them all put together. So it's a highly prevalent disorder affecting about 7.5% of kindergarten-age children, which amounts to at least one and probably two children in every classroom. It also, because it is a language learning disorder, the effects of the disorder are cumulative. So a child may start out having difficulties understanding language or producing language, which then translate into the early preschool and school age years as becoming more socially isolated or withdrawn from their peers. Potentially, then in the later school age years, they may have trouble with reading and spelling and writing, which then translates to a lot of different aspects of their academic careers. They have poor academic outcomes. And in the very long term, these individuals may have difficulty forming meaningful relationships and obtaining gainful employment. So they have poor psychosocial outcomes and poor sociodemographic outcomes. So the recommended best practices for this population are to identify them early and provide them, intervention early. To provide them intervention early so that their language skills can be facilitated early on in life, and hopefully they can avoid some of those secondary outcomes. But the first step in the early identification, early intervention process is to provide screening, because obviously you don't want to provide a thorough language evaluation for every single child. Ideally, you can sort out those kids who are not at risk for the disorder from those kids who are at risk, and then you can focus in on that particular population of children. There are a couple of ways you can go about screening children for language impairment. You can look at early behavioral indicators, such as their production of babbling, their use of pointing and gestures, their use of first words or word combinations, or their participation in symbolic play. An alternative source of screening could be identification of risk factors, such as the child's sex, prenatal exposures or perinatal events that may affect the child's development, family history, which is often portrayed as sort of a genetic characteristic, birth order, and family socioeconomic status. So for this review, I focused in on risk factors for a couple of reasons. The first being that risk factors tend to be observable much earlier on in life. So amongst the early behaviors listed here, babbling is probably the earliest to develop and can only be meaningfully interpreted around the age of 4 to 6 months, whereas the risk factors listed here can be identified at or before birth. So that makes it more accessible earlier on in life, and in addition, they tend to be more universal. So things that you can identify without having a degree in language development or communication disorders, anybody could really identify these issues and then judge the associated, the difficulties associated with having that risk factor. So my research question for this review was, does the evidence suggest that specific risk factors can be used to identify toddlers in the general population who will develop SLI? I went about answering this question using a three-phase approach. In the first phase, I used systematic review procedures to define and identify a cluster of studies that I could use to answer my research question. In the second phase, I used meta-analysis procedures to aggregate scores for individual risk factors across studies and to identify those that are significantly associated with SLI. And so basically, what this amounts to is I wanted to perform individual meta-analyses for each of the risk factors that I was considering. And then the third phase involved determining which of these factors that were statistically significant met criteria for clinical significance. So that's a different sort of scale than just statistical significance. So turning now to the first phase of the project, which involved performing a systematic review. And I have to specify that there have been systematic reviews in the past that have focused on a very related question, that is, looking at the use of risk factors for screening children for speech and language delays or disorders. In particular, there was a systematic review performed for the U.S. Preventative Services Task Force in 2006, and then a follow-up review in 2015. And the findings of these reviews were that studies about potential risk factors enrolled heterogeneous populations, had dissimilar inclusion and exclusion criteria, and measured different risk factors and outcomes. So they basically concluded that you couldn't draw any conclusions because there was too much heterogeneity to actually come up with a meaningful synthesis of the results. So I wanted to avoid the same sort of dilemma. So I set out at the beginning of my systematic review to set out very specific criteria that I wanted the studies that I included in my review to meet. So the characteristics that I chose to define were the participant sample, the outcome of interest in the study, the exposures that were investigated, the age of identification associated with those exposures, and the types of data that were reported. So then turning to participant sample, my research question specified that I was interested in something that could be used in the general population. So my first requirement is that the included studies had to have participants that were recruited from a representative population sample. And I'll get into more details about what I meant by representative later on in the talk. But for the time being, I just want to specify that what I was interested in avoiding was sampling bias. Because especially in epidemiological research, if you have a biased sample, then your association between your risk factor and your outcome can be hugely skewed, either overestimated or underestimated. And if you want something that has population-wide effects, if you want something that can be applied to the population, you want to avoid having this kind of biased result in your study. In terms of the outcome of interest, my research question specified that I was interested in specific language impairment. So my second requirement is that the studies must include a group of participants with SLI who are diagnosed at the age of 4 or older. And I set this criteria because I wanted to avoid, there are a lot of issues with identifying a language impairment before the age of 4, in terms of there are lots of children who are late bloomers who appear to be delayed and then spontaneously recover. There are children who appear to be typically developing who then later exhibit signs of a language impairment. So although it's not set in stone at the age of 4 how your language abilities are going to be, at least by the age of 4 they tend to stabilize more and the diagnosis tends to be a bit more accurate. So that's why I set that limit on diagnosis. In terms of the exposure, my research question specified that I was interested in risk factors. So I defined risk factors as prenatal, perinatal, neonatal, child, parent, or family characteristics that might be associated with language learning abilities and could be collected during a routine pediatric screening. And this point was important to me because there are a lot of things that could be associated with a language learning impairment, but in terms of something that could be implemented in practice, say an 18-month checkup or a 24-month checkup, I didn't want something that was going to require excessive analysis or a lot of time or something that was going to require special instrumentation. So I was really focused in on those things that could be implemented in a routine screening. In terms of the age of identification, my research question specified that I was interested in identifying toddlers. So my fourth requirement is that the included risk factors must be identifiable before a child's third birthday. And this is getting back to the idea of early identification. And then in terms of the data reported, my research questions specify that I was interested in identifying risk factors that are associated with the development of SLI. So my fifth requirement is that the study must provide enough data to calculate odds ratios. So odds ratios are a type of effect size, and for those of you who may be less familiar with this effect size, it's defined as a measure that indicates the association between a risk factor and an outcome. So it's a ratio, the ratio between the odds of developing the disorder if the risk factor is present versus the odds of developing the disorder if it is absent. And so for those of you who are mathematically inclined, you may have already been able to figure out that if you have an odds ratio of 1, that means the two values are the same, and basically indicates that the odds of the disorder are equal whether the risk factor is present or absent. So this isn't really informative for answering that question that I'm interested in. If your odds ratio value is greater than 1, that indicates that the top number is greater than the bottom number, which suggests that the odds of the disorder are greater in those with the risk factor, which is what you want to see to answer that research question. If the odds ratio values are less than 1, that means the bottom number is greater, which suggests the odds of the disorder are greater in those without the risk factor, which isn't particularly informative for answering my research question, and a little unusual, not what you would expect. So, so I was focused in, I wanted to identify those risk factors that were associated with an odds ratio value greater than 1. But I must also point out that for every odds ratio, there are two components. There's the point estimate, which is the estimation of the association between the risk factor and the outcome in this particular study sample. And then there's the 95% confidence interval, which is what the association might be in the general population. So I'm going to give you a few examples to kind of get you familiar with this idea. So first of all, let's take maternal education level as the risk factor of interest. So in one study, it was found that the odds of developing SLI in children who had whose mothers had less than a high school degree was 3 times higher than for children whose mothers did not have a high school degree. So that's interesting, but let's take a look at the 95% confidence interval. And what we see is that the true value could be anything from 1.16 to 8.20. So this is a pretty wide range. And what it tells us is that it could be strongly associated, it could be not as strongly associated. But the thing to take away from the 95% confidence interval is that no matter what the value is, it's over 1. So that indicates that for this particular risk factor, it is statistically significant predictor of SLI. Okay, so let's take a look at another example. In this case, we're looking at paternal smoking during the child's fetal development. So the odds of developing SLI for a child whose father smoked during his or her fetal development is about 1.5 times higher than for a child whose father did not smoke. But let's take a look at the 95% confidence interval. And what we see is that the range of the interval goes from 0.98 to 2.07, which indicates that actually there may not be any association at all, so this is not a statistically significant factor. So now I'm going to take a member of the audience who feels confident in their interpretation of odds ratios to do the last example. Do we have any volunteers?
If I can't do this.
Let's see how
Good teaching.
You want us to analyze the confidence interval?
I'm going to have you do the point estimate and the confidence
I'll
interval.
try.
So, okay. And I'm going to give you a little help. So,
Okay.
Okay, so this last factor is having a young mother. So a mother who's less than the age of 18 when the child is born. So the point estimate is here, and I'm going to start you off by saying the odds of...
Sorry, what was the quality of the mother who was...
Having a young mother, yeah.
Okay. I don't know how to say it. The odds of having...
The odds of developing.
The odds of developing SLI with a young mother is... I don't know how to say that. At least, I thought it was going to be the hypothetical.
I'm sorry.
At least one...
So if you have a mother who's young versus having a mother who's not young, your odds...
It's yeah. It's statistically significant based on the point estimate that you're more likely to have SLI if you're the young mother. Is that the general?
Sure, yeah, okay, that's good. Okay, so then let's take a look at the 95% confidence interval and what you judge based on that.
Well, it's still above 1, so you still have a statistically significant chance above.
So it's tiny, but it's still statistically significant,
Yeah.
which is the point of this example. Very good, thank you.
Thank you.
I was very good if I had something. All right, so going back to the characteristics that I decided to define before going into my review. First of all, the participant sample needed to be representative. The outcome of interest had to be specific language impairment. The exposure had to be risk factors that could be identified in a routine pediatric screening. The age of identification associated with those risk factors had to be before 3, and the data reported had to be odds ratios. Okay. So now that I had defined those characteristics, the next step was to identify the studies that met those characteristics. So I conducted a search in May of 2015 using the following databases that are available to UT's library. And I used this search string, which contains a lot of different terms that have been used to specify children with specific language impairment. And then I searched by title, abstract, or keywords, or by alt text, depending on the database that I used. The results of this database search yielded 365 citations, 190 of which were unique, and then I excluded dissertations, conference proceedings, and books, which resulted in 185 citations that qualified for evaluation. So 185 citations were submitted to evaluation by title, by abstract, and by full text. So first, turning to the title phase, a title was excluded if it was not available in English, if it referred exclusively to a disorder other than specific language impairment, if it referred to specific genes, alleles, genetic loci, or methodology used to obtain genetic data, or if it referred to neuroanatomical structures, neurophysiological measures, or methodology used to perform neuroimaging. And the reason for these last two criteria, getting back to the idea of that routine pediatric screening, so these are things that you could not perform on every child who comes into a pediatric office. They require special instrumentation, a lot of time, a lot of analysis, and so they were excluded. So implementing these criteria resulted in the exclusion of 61 citations.
Can I ask a quick question?
Yes.
I understand the logic about excluding it from a methodological purpose. Do you think you lost some information, though, that maybe in those studies they had those risk factors that you could have included in your analysis? Do you feel like you lost the data? I mean, I understand you're not doing genetic screening or grading, but were the data maybe in those studies, like maybe they were doing
They might have
study
something
with SLI,
about
they had maternal education stuff?
Sure. Yeah, that is possible. And I did come across, say, multiple instances of studies that were focused on something entirely different or reported something like maternal education. And so that's, and I would have to look back, but I bet you that the vast majority of those studies would be eliminated on the basis of additional criteria. So 61 citations were excluded. Then turning to the abstracts, abstracts were excluded if they met any of the first 4 criteria, or if they referred to intervention as being the independent variable, because intervention isn't a risk factor. Hopefully it helps the children in their
That's a good question.
It didn't work on that.
So 12 additional citations were excluded.
How many were in other languages? I'm just curious what the literature's like today.
I don't actually know. I feel like it's probably on the order of 12 to 15,
Curious.
20, maybe, yeah. So then once I concluded the abstract phase of the study, then I did a hand search of, I looked at the studies that I had remaining, and I found that I had 31 reviews and book chapters. So I looked at the citations of these reviews and book chapters, and identified an additional 24 citations that seemed like they might answer my research question. So those, in addition to the 81 citations I had remaining from my database search, resulted in 105 citations that I then submitted to full text review. For the full text phase, I had completely new criteria. There were exclusionary and inclusionary criteria. In terms of exclusion, a full text is excluded if the author is recruited from a population known to be at risk for SLI. And this is getting back to the idea of having a representative population. If you already have a population that's at risk, it's going to throw out the association between that risk factor and the outcome. I then also excluded a full text if the authors included participants with SLI who are under the age of 4 years, getting back to the accuracy of the diagnosis. In terms of, yeah.
So under number 1, I'm thinking about like the study Susan Ellis Weisberg and I did, right, where we followed 50 typical kids and 50 late talkers, and we picked them up at 18 months. Some of those kids in the typical population might have been classified at 4 as late talkers, but you would have excluded it because we were recruiting based on late talker and typical. But the normal kids out of that might have actually been valuable for you to track. Because we had 50 of the typical kids included.
Yeah.
Would you have lost
might
that
have been
study size criteria?
Yeah, it would not have been included because of this criteria.
Even though the normal control group might have provided a possible data.
Yeah,
Because
so
they're not being selected based on
Right.
anybody.
right. Yeah, that's absolutely true. But in terms of thinking about the population in the study, so I guess if there had
Because your
been
normal controls by definition at 18 months.
right, exactly. So
No, yeah, you
you need to have a
could.
follow-up study of those kids, and it would have to say which one
They're
is
longitudinal. No, I'm not following.
Well, if there's so what I
I followed
imagine
them
is
until they were 5.
right,
So
and so then you
would
have your SLI group and your TD group at 5.
So we had late talkers and typicals at 18 months.
Right.
We followed all 100 kids till they were 5, and they knew what their outcomes were.
Right, so
And
SLI or TD.
Some of the kids in the normal control group who
Ended up
ended up
being
being
SLI.
right. So
Yeah.
those would have been examples of a clean population, right? Or am I not?
Just that group.
Just not the general population.
Right.
That's the point.
Right. Yeah, so that group would be an example of the general population
Yeah.
potentially, but then you also have that group of late talkers.
And I'm saying you
who would
wouldn't
be-
include the late talker data. But couldn't you just use the normal control? I'm asking just for an additional follow-up of more data points was all. In theory, she could have used the normal control.
Anyway, you better get.
No, I'm
we
trying to
better-
understand
No,
the
no.
method. I'm sorry.
Yeah,
No, but I mean, this is, I'm
And
just
I
saying,
was asking it
it's
from
a great question and worth a lot of discussion. It's just.
I would have asked it at ASHA.
Yeah, absolutely. Yeah,
Sorry, don't mean to derail you. Go ahead.
no, it's fine. So I think what my thought was is if the populations we recruited were late talkers, I anticipated that if late talkers were in the sample and they were included in the final, and then the odds ratios would be between a group, some of the late talkers would be in one group, some of the other potentially, but they would be included in, recruited just based on their late talker status, which makes them not representative of the population.
No, I get that.
So that was my thinking in terms of that. In terms of what was included, full text was included if the authors used a single gate recruitment approach. So for those of you not familiar with this concept, I'll introduce a quick animation. So there are basically 2 ways to recruit participants into a study. One way is by sending out a single set of procedures and guidelines, and every participant in your sample enters through that same door. There's an alternative way of recruiting participants in which you set out 2 sets of criteria and 2 sets of procedures, and you have one group that enters through one door and one that enters through the other door. So in this case, typically what this would look like in a study is if you want a group of participants with SLI, you go to clinicians, a clinic or a hospital or a school, and you say, give me your participants with language impairments. And then so those have become your SLI population. And then for the typically developing group, you go to, say, a school and you say, give me any of your kids who are not getting speech therapy. So already at the outset, you know that those 2 groups differ systematically. And so in terms of having a representative population, it's very unlikely that having those 2 separate groups is going to be representative of the general population. So that was my first inclusionary criteria. In terms of my second inclusionary criteria is that the authors had to include one group that consisted exclusively of children with SLI. So there are some studies that looked at clinical risk factors for clinical populations, and maybe that clinical population included kids who were stuttering or kids who had pragmatic deficits, in addition to kids with just language impairments. So I wanted an SLI group in this study. My third criteria is that they had to include one group that consisted exclusively of children who had typical language development. And that was my comparison group for calculating the aggregation. And then full text was included if the authors examined one or more risk factors that could be identified before the age of 3, getting back to the early identification. And then my 5th criteria is that the authors had to provide odds ratio values or enough data to calculate odds ratio values for the risk factors they investigated. So based on these 2 sets of criteria, an additional 97 citations were excluded, which left me with 8 studies that could then be included in my systematic review and meta-analysis. Now, I need to point out that among these studies, there were 4 that actually focused in on the same population of participants. This is the Iowa Tomlin sample of children. These studies investigated different sets of risk factors, so they're not entirely overlapping. However, there were some risk factors that did overlap from one study to the next. And in that case, say something like maternal education level was reported in each of these studies, I would only take maternal education level from Tomlin et al. 1997A, and I ignored it in the rest of the studies, so that I only had one effect size representing maternal education for this population.
So my only data was coming off the PC&D longitudinal.
I'm sorry.
You might check the Riley paper as well, because that's off the PC&D longitudinal, and they follow those things from 7 all the way up, so they have multiple studies on this.
Yeah, I've seen, so you're saying there's just one past 2010?
Well, I was talking about it.
Okay, sure. Okay, so once I identified this cluster of studies, I decided to take a step back and look at, did I accomplish my goal in setting out my criteria with the populations in these studies? So what we see here is that, I'll just put it on the screen. So almost every study had over 1,000 participants, with one exception. Then in terms of the division between children with SLI and children with typical development, we see that a higher proportion of the children were in the typically developing group, which is what we would expect to see in a representative population, because only a proportion of kids actually have a language impairment. So that looked to me like it was at least matching up with the general population in that way. And in terms of the ages of the children, of course, they're all over the age of 4, go as high as the age of 8. And then all the studies took place in English-speaking countries, which might limit the applicability of the results, but also because I was interested in risk factors that aren't language specific, then it's likely that the results of this review could actually generalize beyond English-speaking populations. In terms of my disorder group, what we see is that each study implemented a series of exclusionary criteria to make sure that the kids were SLI. And we see that all the studies excluded children with hearing impairments, cognitive impairments, the vast majority excluded children with social impairments, and neurological damage. And then also the vast majority of studies excluded children who were multilingual. Not that being multilingual is an impairment, but these children have a different trajectory of development than monolingual children. So I anticipated, based on this, that my disorder groups were going to be relatively similar to one another across the studies. So moving on to phase 2, performing meta-analysis for the risk factors. Here I have a word cloud that lists all the risk factors that I extracted from all of those 8 studies. And the size of the word is not associated with the strength of the risk factor, but rather with the number of studies that investigated it. And this is important because in order to perform meta-analysis, you have to have at least 2 effect sizes and ideally more than 2 effect sizes representing any one of your factors. So what we see here is that there are some factors that stick out as being investigated in multiple studies. But what we also see is there are a whole host of other factors that were looked at in only one study, maybe 2 studies. And for me, this was problematic because that would be a lot of data loss in terms of the things you have to exclude because they don't meet the criteria for meta-analysis. But if you look at some of these characteristics, there are things like abnormal heart rate, that is during the birth, need for resuscitation, NICU placement. There are a lot of birth-related variables. They fall generally into prenatal, perinatal, and neonatal categories. So I decided to create what are called combined variables. So I had things like kidney infection, thyroid issues, STD, UTI, or type 1 or type 2 diabetes that the mother had during the pregnancy, and these I combined into the variable maternal illness. Then I had things like anemia, preeclampsia, gestational diabetes, hypertension, hyperemesis that were associated with the pregnancy itself, and I combined those into the variable pregnancy condition. Then I had things like maternal and paternal smoking, illicit drug use, alcohol, or occupational exposure to toxic substances or other chemicals, and these I combined into the variable prenatal exposure. Then in terms of perinatal characteristics, I had things like delivery by cesarean section, use of forceps, induction or breech presentation, and a lot of other things that I then combined into the variable perinatal event, so anything that occurred during the birth of the child. And then I had 1 minute and 5 minute APGAR scores, time to spontaneous respiration, need for resuscitation, NICU placement, jaundice, difficulty with temperature regulation, and those were combined into the variable newborn condition. So once I had combined, or had created these combined variables, the picture became a little clearer, and I had, of course, my combined variables that had been examined in more than one, in 2 or more studies, and on top of those, I had things like birth order, birth weight, maternal age of the child's birth, maternal education, male sex, family history, SES, marital status, and prematurity, that were then all eligible for meta-analysis. So this is 14 variables that I could potentially submit to meta-analysis. However, it's important to point out that just because something is eligible for meta-analysis doesn't mean that you should perform meta-analysis. If there's significant heterogeneity across the studies due to systematic differences between those studies, then aggregating those values is going to get you to something that is not actually representative, because those are 2 different populations. So I anticipated that given the criteria set out before, that my studies would be relatively homogeneous, my effect sizes would be homogeneous, because I had representative samples, my disorder groups met the criteria for SLI, my comparison groups was always children with cyclically developing language. I had similarly defined risk factors, and odds ratios were the statistic that was always reported and calculated. However, there was one thing I didn't control for, and that was whether the studies reported adjusted or unadjusted values. Let me give you a quick summary of what it means to be adjusted or unadjusted. So typically when you calculate an odds ratio value, you have what's called a 2x2 contingency table, in which the exposure is listed in the rows and the outcome is listed in the columns, and every child in the study falls into one of those 4 categories. And you calculate the odds ratio, which, as I mentioned previously, is a ratio between the odds of developing the disorder for those who are exposed to the risk factor over the odds of developing the disorder for those who are not exposed to the risk factor. If you put those values into this equation, you calculate what is called an unadjusted odds ratio. Alternatively, you can calculate an odds ratio by performing multiple logistic regression. And what happens in this case is you enter your variables of interest into the analysis with potential confounding variables. So let's take as an example, say we want to know the association between maternal smoking and an outcome of SLI. Say we know that there is an association between SES and maternal smoking, and there's an association between SES and SLI. So what if the association we see between smoking and SLI has to do somewhat with the association between SES and smoking? Well, so if we throw all those variables into multiple logistic regression, our variables of interest are adjusted for the association with the confounding variables, and we have what is called an adjusted odds ratio. So even though the 2 studies may actually be very similar in all other ways, if one reports an unadjusted value and one reports an adjusted value, you may have actually systematic differences between those values. So I decided ahead of time that if I came across a variable for which the effect sizes were very heterogeneous, that I was going to perform what's called a moderator analysis. And in a moderator analysis, let's take, for example, say I had family history and there was a lot of heterogeneity in the effect sizes. I perform a moderator analysis in which the adjusted effect sizes are put into one bucket and the unadjusted values are put into another bucket. And then you look at the heterogeneity within and between those subgroups. So what you want to see is that they're homogeneous within the buckets, but then between the buckets, that's where the heterogeneity exists. So that indicates that the heterogeneity observed for the bigger factor is actually due to heterogeneity across the groups. Okay? And I decided that if I came across a risk factor for which moderator analysis produced this result, I was only going to take the adjusted odds ratio values going forward. Okay, so, but what do I mean by significant heterogeneity? Well, there are two metrics that I looked at to determine whether heterogeneity existed. The first was Q, which is a chi-squared statistic that describes the deviation of each individual effect size from the mean effect size. So the greater the deviation, the bigger the Q, the smaller the P. But Q isn't a very sensitive indicator, so I set my P value at 0.1. So it was significant heterogeneity existed if P was less than or equal to 0.1. My second statistic of interest was I squared, which was an inconsistency index that describes the percentage of variation across effect sizes that is due to actual or systematic differences between the studies versus just random sampling error. There are bound to be differences. Some of them are random, some of them are systematic. So I set as my criteria for I squared 40%. So I said that significant heterogeneity existed if 40% of the variation was due to actual differences between the studies. Okay? On the flip side, homogeneity was defined by having a P that was greater than 0.1 and an I squared less than 40%. So this is important to keep in mind because I'm just about to test you. So keep these levels 0.1 to 40% in your head. Here we go. So here are the results of the heterogeneity analysis. What is the first variable that met the criteria for heterogeneity? Birth weight, very good. So even though the P met the criteria, it's over 0.1, the I squared was 50%, which means that it met that criteria based on the I squared. Okay, what's the next one? Maternal education, all right. Next. Pregnancy condition, and there's one more.
SES.
SES, very good. Okay, you guys found them all. So one thing I forgot to mention. So of course, what I wanted to go forward is to perform moderator analysis on these variables. But in order to perform moderator analysis, it's the same criteria as for a meta-analysis that you have to have at least 2 effect sizes in each of those subgroups. So I had 2 variables that did not meet that criteria. I could not perform moderator analysis. But let's look at the results for the other 2 variables. So here we have maternal education, and I'm going to introduce you to, this is a forest plot. We have 1 is the central line, so 1 is that boundary of non-significance that we talked about before with odds ratios. To the right are effect sizes that favor the group with SLI, meaning it's associated with SLI. To the left favors TD, so ideally we want everything to the right of that line. And what we see here is we have 2 studies that reported adjusted odds ratios for maternal education and 2 that reported unadjusted values. And then we have the combined effect sizes for those 2 groups. And what we see is that the adjusted value is less extreme and has a narrow confidence interval, which is what we would expect for an adjusted value. But let's take a look at the heterogeneity. And what we see is that within those subgroups, that the P was 0.780. That's greater than 0.1, so that indicates there was homogeneity within the subgroups, which is what we want to see. In terms of the heterogeneity between subgroups, the P was 0.007, definitely less than 0.1. So what this indicates is that the heterogeneity we observed for maternal education was actually due to adjustment. So going forward, I only took the adjusted values in performing meta-analysis. Yeah.
So why did you choose the adjusted? I'm just curious, because I will get later to ask that. Why the adjusted instead of the unadjusted? Because wouldn't the adjusted be influenced by what is it being adjusted for? And do you think that differ across the studies? Or
Yeah, generally speaking, they adjusted for everything they put in. But the point here is that, or the important takeaway is that the adjusted value is a more representative idea of what the real association is, and so that's why I wanted to use those values going forward. Then looking at pregnancy condition, the picture is not quite as pretty. We have, again, 2 studies that reported adjusted values and 2 that reported unadjusted values. Here are the combined effect sizes. The unadjusted values are kind of all over the place. But looking at the heterogeneity statistics, we see that P was greater than 0.1 within subgroups, which indicates homogeneity. And P between was 0.059, which indicates significant heterogeneity between subgroups. So going forward, I only took the adjusted values for pregnancy condition. Okay, so now that I have all of my variables homogeneous, I can perform meta-analysis. And here we have our aggregate scores for each of those variables. So here are the point estimates for the odds ratios, and what you see is that almost all the values were over 1, which is what you'd like to see, with 2 exceptions. But the important thing, as you know, is looking at the 95% confidence interval. So looking at those, we see that there are 6 factors for which the lower limit of the 95% confidence interval is greater than 1. However, one of those was newborn condition, which, if you recall, was one of those combined variables that I created. So I was interested in knowing, well, what's responsible for this significant effect. I did a post-hoc analysis of newborn condition. Amongst all the variables that have been included in this combined variable, 5-minute APGAR was the only one that had been investigated in more than one study. So I performed meta-analysis for this variable. The statistics of heterogeneity indicated that it was homogeneous across effect sizes, and the aggregate effect size was significant. So I decided going forward to consider 5-minute APGAR a distinct variable from newborn condition. So looking back at our aggregate scores, we see here that newborn condition is now no longer significant. But we do have 6 statistically significant factors: low 5-minute APGAR score, having a positive family history of communication or related disorders, male sex, low maternal education level, later birth order, and having a young mother. The next question is, well, which of these are clinically significant indicators? So before we can say that, we have to first define what we mean by clinical significance. There's no set standard. I decided to go with a metric that is called number needed to harm. And what this metric indicates is the number of children who have to be exposed to the risk factor in order for one child to develop SLI who would not have otherwise. This is kind of a complicated concept, but so to get at the idea, I'll give you an example. So if you have a number needed to harm of 1, that indicates that every child exposed to the risk factor develops SLI. So that's a really bad risk factor. You really don't want to have that. So low NNH means bad risk factor. So I decided, in deciding what value for number needed to harm would be a clinically significant value, I turned to something that I know is very controversial, but also very commonly used both amongst pediatric professionals, amongst child care providers, and amongst parents, and that is delayed development of expressive vocabulary, or being a late talker. Now let's take, for example, a sample of 5,000 children. We know based on research that about 7.5% of those children will be SLI, so that's this column here. We also know that about 15% of those children will be late talkers, so that's this row here. And we know that among those late talkers, about 10% of those children will go on to have chronic language deficits, and that's this value right here. So in thinking about a number needed to harm, it's the difference between the incidence among those who have the risk factor versus those who do not have the risk factor. And so in this case, that difference was 0.029. The inverse of that is the number needed to harm, which is 35. So that indicates that 35 children have to be late talkers in order for one child to develop SLI who would not have otherwise. So I set as my minimum boundary of clinical significance the number needed to harm of 35. But how does that translate to odds ratios? Because that's my effect sizes. That's what effect sizes are reported for my risk factors. So first of all, you need your minimum or maximum number needed to harm. In this case, was set at 35. You also need your prevalence rate, or patient expected event rate, which is 7.5, the prevalence of SLI. And then based on those two numbers, you can calculate an odds ratio, which came out to 1.43. So that was my minimum boundary of clinical significance. Any risk factor for which the lower limit of the 95% confidence interval was greater than or equal to 1.43, I set as clinically significant. Okay, so let's take a look back at our forest plot. Again, here, 1 is that boundary of non-significance. Anything between 1 and 1.43 met criteria for statistical but not clinical significance, and anything beyond 1.43 met the criteria for both clinical and statistical significance. Okay, so let's take a look at our 6 risk factors of interest, and what we see is that there are 2 factors that actually fell entirely within the boundary of clinical significance, 2 that fell mostly within that boundary, and 1 that kind of crossed over, and 1 that didn't meet that criteria at all. So, turning back to my research question, does the evidence suggest that specific risk factors can be used to identify toddlers in the general population who will develop SLI? Well, based on the criteria I set for clinical significance, which maybe was a low bound, but the answer to this question would be yes. There were 6 statistically significant factors. Among those, maternal education and sex met the criteria for clinical significance. And then there were 3 others that fell within the limits of clinical significance, but didn't quite meet the criteria. Further investigation is needed to know whether these characteristics actually do meet clinical significance criteria. And then recall that there were 2 factors that could not be aggregated due to significant heterogeneity. Those were birth weight and socioeconomic status. Amongst these, birth weight in one of the studies that had investigated fell within the bounds of clinical significance, so it is also worthy of further investigation. And there were 10 factors that could not be examined at all because they had only been looked at in one study. Amongst these, there were 4 that in their individual studies had fallen within the bounds of clinical significance and therefore may be worthy of further pursuit. So conclusions are that sex and maternal education levels should probably be considered when deciding whether a child is at risk for significant long-term language deficits. And there are a number of risk factors that are worthy of further investigation to determine whether they're clinically significant or not. And that it may be that the right combination of risk factors may actually be most indicative. So let's say we have a little tyke his father has a history of dyslexia, and he's the 4th born child in his family. What are this child's odds of developing SLI? We don't know because we need to know what that combination of risk factors would entail in terms of this risk. It could also be that the best screening tool actually involves a combination of the most predictive risk factors and the most predictive early behaviors. And that if you pick the right set of behaviors and risk factors, you may get a screening tool that is both precise and accurate in its estimate, and therefore facilitates that early intervention process to a much greater degree. Are there any questions?